So let's look at the cardiac system. As we mentioned in class, the main function of the heart is to pump blood to all parts of the body. Of course, nobody will ask you what the function of the heart is when it comes to the cardiac system. But knowing the function will help you identify when something is wrong. So main thing that they're going to be asking you for the NCLEX is going to be health promotion, and we're talking about perfusion. Perfusion, we said that is the transport of the oxygen to all parts of the body. So if the heart fails to pump, then other parts of the body will not be able to get oxygen. And so our main problems we're going to be dealing with is going to be perfusion problems. There's one thing I want you to understand. First of all, the heart itself, when it is pumping blood to all parts of the body, it will also have to pump blood to itself. And so blood will always be going through blood vessels. There are two major blood vessels that you need to know, and these are the arteries and then the veins. When we talk of arteries, they carry oxygenated blood. The veins, on the other side, they carry the deoxygenated blood. In case of the cardiac system, the blood vessels are going to be referred to as coronary. So anytime you hear the coronary, this word, coronary, it means we're referring to the blood vessels that supplies and take blood away from the heart. So when you hear coronary arteries, these are the arteries that supplies the blood and the heart with oxygenated blood. And then when they talk about coronary veins, they will be the one that will take blood away from the heart. So please take note of that. So when you talk of coronary artery disease, it refers to the coronary arteries. These are the arteries. It means we have problems with these arteries. We'll talk about that. But the major coronary artery disease you're going to be talking about, as far as NCLEX is concerned, is going to be the building up of cholesterol in any of these coronary arteries. So when you are building up cholesterol in the coronary arteries, it is called um, coronary artery disease, or it result, not called coronary arteries, but it result in coronary artery disease, which means that blood will not be able to be flowing freely to and fro to all parts of the to all parts of the heart. The building up of cholesterol in the coronary artery disease is what we called atherosclerosis. And that is the major ones that you need to know as far as NCLEX is concerned. So we'll be talking about the aorta as well, but I'll be referring back to this image very often. But what I want you to know is that the main function of the heart is to pump blood to all parts of the body. And when that fails, then we have a fusion problem. That's oxidation to any part of the body that needs the oxygen. Health promotion questions will be like teaching the patient about how to prevent heart diseases. We'll talk about that as well. So the main thing I want you to understand is these blood vessels, coronary arteries, they carry oxygenated blood to the heart itself. And then if we have any problems in this area, in any of the coronary arteries, then we say that we have coronary artery disease. One of them is the building up of cholesterol, which is called atherosclerosis. So when we have a cardiac problems, the main thing we're going to be looking at is the diagnostic test. So please look at this well. The labs that you need to know for the NCLEX. As far as labs is concerned, we have cardiac markers. So these labs, when you see them in question, it tells you some kind of conditions that is going on. The first one I'm going to talk about is troponin. When troponin levels goes up, it means that oxygen is being cut off from reaching to any part of the body. So either we have a blockage in this coronary artery, and as a result of that, the cells that are supposed to be receiving the oxygen it's no more getting them, and then the cells begin to die. Now, when cells die, it is called infraction. So when it happens to the cardiac cells, we call it myocardial infraction. So MI. And the lab that actually will tell you that we have a myocardial infarction is troponin. The other lab I want you to understand is going or take note of is the creatinine kinase. When you talk of creatinine kinase, this is where you have muscle cells that are being damaged. And the heart is made up of muscles. So definitely when you have infraction in the heart, what is going to happen is that you expect this creatinine kinase to go up. But the problem is that this is not cardiac specific, you know. So you have other muscles that are broken down, this creatinine kinase will go up as well. So the one that is more cardiac specific, which we can say that for sure, is the cardiac muscles that have been damaged is a troponin. At the same time, when troponin levels goes up, creatinine kinase will go up as well. But creatinine kinase is not always an indication that the heart muscles are the ones that are damaged. Just take note of that. So in the case of rhabdo, you will use the creatinine kinase. You notice that the patient's urine is going to be dark. The next lab I'm going to talk about is the CBC, which is the complete red blood cells. Now, the main function of the red blood cells is to carry oxygen to all parts of the body. So when the red blood cells levels goes down, it tells us that then we have problem with oxygenation. The person will not get enough oxygen to all parts of the body, and so they can easily become fatigued. Conditions such as rheumatoid arthritis will result in decreasing the number of red blood cells that we have. And when the red blood cells levels goes down, then of course we have problem with oxygenation. Um, there are also other conditions that will result in the increase in the red blood cells. When your red blood cells levels goes up and they are normal, which means that your oxygen current capacity is going to go up. One of them is when you live in high altitudes. In the case of, for example, let me use Kenya for example. There are a lot of mountains in Kenya. They live in a very high altitude. And so, by nature, their body is being adapted in such a way that they have enough um, red blood cells to be able to use the limited oxygen that they found in the environment. And so when you somebody from Kenya decide to go to an area where there is abundance of oxygen, they have a very good advantage because they do have enough red blood cells to capture a lot of oxygen, and therefore when it comes to long distances they can run and run and run and run without getting tired compared to somebody who has fewer red blood cells in them or normal red blood cells. Now, the next one I'm going to talk about is going to be the white blood cells. Please take note of that. With the white blood cells, we know that anytime white blood cells goes up, it's an indication that we have some kind of infection going on in our body. Now, for now, this is the first thing that comes in your mind when white blood cells levels goes up. And as we speak right now, you need to now upgrade your mind as far as cardiac system is concerned. When you have myocardial cells damaged, we still need the white blood cells for them to clear the dead cells. And so when somebody gets MI, the white blood cells will also go up as well. So it's not always that when white blood cells goes up, it's a sign that the person has an infection. One option is that yes, the person has an infection. The other option is that the person will have a myocardial infarction as far as cardiac is concerned. So, how do you differentiate between myocardial infarction, white blood cells going up, and also an infection, white blood cells going up? Please, when that happens, look at what we call the temperature. In the case where you have these case studies, check the temperature. When the temperature levels goes up, it's an indication that it's an infection. So in the case of endocarditis, which is a bacterial infection to the heart, you expect the white blood cells uh, to go up, and also you expect temperature to go up. But in the case of MI, you don't expect the temperature to go up because it's not an infection, but the white blood cells will go up as well because we need the white blood cells to clear the necrotic or the dead tissues. So that is what happens when somebody get MI and then the white blood cells goes up. I hope that is clear. So when white blood cells goes up, it's not always an indication that there is an infection. One of the options is that yes, there's an infection. The other option is that there will be this cells damage. That's myocardial infarction, and the white blood cells will go up. To differentiate the two, use the temperature. When temperature goes up and white blood cells goes up, it's a sign that there's an infection. The other lab I'm going to talk about is hematocrit. So when you look at hematocrit, we're talking about the solute portion of the blood. So in this case, when you have dehydration, that means that the concentration of the solute in the blood is going to be going up. And so when hematocrit levels goes up alone, it's an indication that there is a dehydration. On the other hand, when hematocrit levels goes down, it means that you are having fluid overload. So in the case of heart failure, we expect the hematocrit levels to go down. Or fluid overload, the um, the hematocrit levels will go down. Now, this is also another lab I want you to also take note of. We have hemoglobin, which carries the oxygen to all parts of the body, and then hematocrit, which I said that is a solid portion of the blood. When these two levels goes down, it's an indication that the person is having anemia. So please take note of that. So anytime you hear anemia, the first thing that should come in your mind is H and H. Okay, the H and H stands for hemoglobin and hematocrit. When the two levels are going down at the same time, it's a sign that the person is having anemia. There are different types of anemia. We have sickle cell anemia, iron deficiency anemia. Um, there are so many. So if the person is also bleeding, we also expect the H and H to go down. So this is a lab that tells whether we have to transfuse blood or not to transfuse blood. The other labs I'm also going to talk is going to be blood coagulation factors. Now, when we talk blood coagulation factors, this is where we determine whether the persons can clot their blood or they cannot clot their blood. So whenever any procedure that involve um, bleeding, the doctor will order the coagulation factors to be carried on. In this case, we want to know if the blood after the procedure and the person's blood clot or to stop the bleeding. So if the coagulation factors are released, there's one thing you also have to know. These are factors or these are things that will help the blood clot. So whenever they are being released, this person is also at risk of getting blood clot. So in the case of myocardial infarction, where cells are damaged, this coagulation factors will be released. And when they are released, the doctor will be more concerned about blood clot going on in the heart, or this blood clot can also go to the brain and cause stroke. So anytime we have MI, the doctor will also try to figure out the coagulation factors and then it put this person at risk of getting a blood clot. In order to do that, the doctor is going to put the patient on anticoagulant to prevent this blood from clotting, especially when the person has MI. So anytime you identify that the question says that the person has MI, one of the greatest risks is blood clot, and therefore you expect the doctor to put the person on anticoagulant. The two major anticoagulant I want you to be aware of is going to be um, heparin. And so anytime we hear heparin, is to prevent the blood from clotting. The other one is going to be warfarin. Now, anytime you hear these two anticoagulants, which is mostly tested, it's not enough for you to know that, oh, the two major anticoagulants that we have are heparin and also warfarin. Now, you need to also know that heparin is for short-term use. And heparin, they act right away to prevent the blood from clotting, especially when the person has MI. Whenever somebody is on heparin, the first thing you need to know, or which NCLEX can test you, is that how do we determine the therapeutic levels of heparin? We use the APTT. So please don't forget this one. We call it APTT. Now, this APTT will be the one the doctor is going to order, which we usually we check that every 6 hours until the person is therapeutic. And this will prevent the blood from clotting. In the case of warfarin, um, when a person is on warfarin, the doctor will order this lab INR. The INR is there to monitor the warfarin level. So if you work in the nursing home, you'll be checking patients that are on warfarin, their INR. The good thing is that with INR, you're not supposed to know the therapeutic range. NCLEX will give that to you. But what you need to know is that when INR is low, then it's an indication that the person is at risk of developing the clot, developing the clot. And if HPTT is high, oh, sorry, the INR is high, is an indication or the person is at risk of developing of bleeding. Sorry, the person is at risk of bleeding because the person is having too much of the warfarin. So with warfarin, what you need to know is that when you have too much, when INR levels goes up, it's an indication that the person is getting too much of the warfarin, and therefore the doctor will have to lower the dose. And you also be watching for bleeding. The other thing that they can ask you about warfarin is that when the person is on warfarin, the antidote of warfarin is vitamin K. Okay, vitamin K. Now, with vitamin K, what you need to also understand is that with vitamin K, NCLEX will be looking for food that you need to maintain their consumption for the warfarin to be able to work. So one of them is going to be the green leafy vegetables. Now, there's one thing I want you to understand. As far as warfarin is concerned, when a person is on warfarin, they don't stop taking the the green leafy vegetables. They don't also avoid them. They don't limit them. They don't increase them. But what they have to do is that they have to maintain the amount of the green leafy vegetables that they are taking. They need to maintain that. Too much of it will not help because you have too much vitamin K, and which means that the warfarin is not going to be working the way it's supposed to work. Now, if you also consume too low, it means that we'll have too much of the warfarin in the system, and it's also going to increase the person's chance of bleeding. So please take note of this. Warfarin is an anticoagulant. The antidote is protamine, is vitamin K. Vitamin K is mostly found in green leafy vegetables, and therefore, one thing you need to educate your patient about vitamin K is that they have to maintain the consumption of the vitamin K. Very, very important. They will ask you on that. So if somebody falls and they are on warfarin and then you notice that they are bleeding, then you expect that the doctor will order vitamin K for them and to help stop the bleeding. On the other hand, if the person is on heparin, for heparin, there's one thing that you need to know. Heparin is going to be more of protamine sulfates, okay? Protamine sulfate is going to be the antidote. So when the person is on heparin and they are getting too much of it or they are bleeding, then what is going to happen is that the doctor will order the protamine sulfate to stop the bleeding. So in this case, if the patient fall or the patient is bleeding and they are on heparin to help stop the bleeding, they will not use vitamin K, but they will use the protamine sulfate. Again, to determine the therapeutic levels for heparin, you are going to use the APTT. So don't forget that. There are situations where the question will ask, so because heparin usually acts right away, and heparin is going to take sometimes weeks before they kick in. So when somebody is at risk of blood clot, the doctor will put the person on the heparin first, and then they will also put them on the warfarin as well. But the thing is that the warfarin is not kicking in. It takes some time before it kicks in. Whilst the heparin is helping prevent the clot, the doctor will be monitoring the INR. And once the INR hits therapeutic levels, then the doctor will discontinue the heparin. I have seen questions like that as well. So please take note of that. If you need more questions on this, or if you need clarification when we meet in class, you let me know. So will take us to the end of these coagulation factors as far as anticoagulants are concerned. Take note of heparin and that of warfarin. Please do not confuse the two. Now, our next one I'm going to talk about as far as labs is going to be serum lipids. So with lipids, think about cholesterol. That is mostly that is going to be tested most of the time. When you have this cholesterol or triglycerol building up in your body, or you have high levels, it put the patient at risk of developing what we call coronary artery disease. So the building up of this cholesterol, the triglycerol, is what we call atherosclerosis. So this will put the person at risk of developing the coronary artery disease. So which means that when you come back here, there's a clot in this coronary artery. So when there's a clot over here, it prevents blood from reaching this side. So the first thing that is going to happen is that the person will be talking about chest pain. But since there's no complete blockage, there's still blood going on here. So there's going to be a chest pain, but this chest pain, it will be referred to as angina. Now, if time goes on and we do not clear this buildup of cholesterol, and then we leave it there unchecked, and then it keeps growing, 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 and then there's a complete blockage of this um, of the coronary artery. This time around, we call it ischemia, and which means that cells over here will not get the oxygen anymore, and those cells will begin to die. When that happens, we say that the person is having MI, myocardial infarction. So when myocardial infarction occurs, we expect troponin levels to go up. And so that is all what myocardial infarction is all about. So once myocardial infarction also happens, then as a nurse, you should be thinking about one thing. This person is at risk of developing clot because the clotting factors are going to be released. And if the clotting factors are released, then what is going to happen is that the doctor will say, no, this person is at risk of developing clot. Let me put the person on the anticoagulants. And the two major anticoagulants we mentioned are the heparin and the warfarin. So this is the heparin, warfarin, and again, you know that with heparin, the antidote is protamine sulfate. The lab that we use in determining heparin levels in the blood is APTT. So please take note of that. High levels of the APTT means that the person is getting too much of the warfarin, and therefore it put the person at risk of developing a clot, of bleeding. And low levels of the heparin, when APTT levels comes low, it means that we have low levels of the heparin, and therefore the person is at risk of developing clots. Please take note of these two things. All right. So now you understand what lipids play. So usually the doctor will order your lipid levels. It's there to determine whether you are at risk of developing a coronary artery disease or not. Next, I'm going to talk about is potassium. Sorry, electrolytes. So when we talk of electrolytes, the major electrolytes we're going to talk about is potassium, and we have sodium, and then last but not the next one is calcium, and then the last one I'm going to talk about is magnesium. Please take note of this electrolyte. They like asking about them. So let's come to potassium. As far as NCLEX is concerned, potassium is something that you cannot mess up with. Once potassium levels goes down, it is called hypokalemia. And when hypokalemia occurs, all that we are looking for is ventricular dysrhythmia. So when your ventricles are messing up, we have problem with oxygenation, because whenever the ventricles contract, what happens is that they pump blood to either the lungs for oxygenation, or if it is the left side of the ventricle, it pumps blood to all parts of the body for oxygenation, which is the perfusion. So when we have a ventricular problems or ventricular dysrhythmias because the person is hypokalemic, it becomes a major problem. So with NCLEX, anytime potassium levels goes down, there's a bigger problem. You do not want to mess that way. That. So one of the things that the NCLEX is going to hit you on is that when the potassium levels goes down and the patient is on digoxin, this medication, please take note of this. Digoxin is given to people who have a heart failure, and it helps increase the contraction of the heart. So that is digoxin. They like asking digoxin a lot. I'll talk about digoxin later on in terms of the therapeutic levels and also digoxin toxicity. But one of the things that increases digoxin toxicity, which means that we have high levels of digoxin in the system, is going to be hypokalemia. So when the person's potassium levels are low, think about digoxin. Now, with digoxin, there are a few things I want you to remember. Anytime you're also the person is on digoxin, NCLEX might also ask you or might also test you on what to assess before you give digoxin. And one of the things that you need to remember is the heart rate. Anytime the person is on digoxin, you need to check the heart rate, and it's going to be 1 full minute. Anything less than 60, you need to hold the digoxin and clarify it with the provider before you give it. That is tested most of the time. So don't joke with digoxin. And one of the things that can increase digoxin levels is when your potassium levels are low. Next is that when it comes to electrical activity of the heart, where you can get EKG, to know whether potassium levels are low, is that when you see this U wave, or in question, when you see U wave, it's an indication that the person is hypokalemic, and therefore the person is at risk of having ventricular issues. So that thing is going to be ST depression, and also when you have flattening of the T wave. But mostly when the person's potassium levels goes down, you'll be expecting the U wave. So anytime you have U wave which is low, ST is low. So everything that is low here on the EKG is a sign that the person is hypokalemic. And when the person is at hypokalemic and they are on digoxin, please take note of that. It increases digoxin toxicity. Before you give somebody digoxin, check the heart rate. 1 full minute, heart rate lower than 60. This you have to report it to the provider. Don't give it, hold it. On the other hand, when the EKG is also taken and then we have hyperkalemic, we can also suspect that. The major problem we are going to also be thinking about, which is the complication, is the same ventricular dysrhythmias. So you can see that either low potassium, high potassium, they all cause ventricular dysrhythmias. But high potassium will not cause digoxin toxicity. It is only the low potassium. Take note of that. With the hyperkalemia, everything is this one. I'm not going to focus much on it, but the T wave will be tall or will be peak, and then also the QRS will be widened, and there'll be a prolonged PR interval. And sometimes the P wave get flattened. So please take note of that. But what I want you to understand with hyperkalemia is that it can cause ventricular dysrhythmias. It can also cause asystole, but the whole thing is that either low potassium, high potassium, this person is at risk of developing um, ventricular dysrhythmias, and all the ventricular problems, they are not good. Anytime you have ventricular problems, you have oxygenation problems. Next, I'll talk about sodium levels. Now, with sodium, it is not about the heart. Sodium is more neurological. So you think about altered mental status. When sodium levels are either low or high, please think about altered mental status. That is sodium levels. Now, when the person is on diuretics, that is when they are peeing too much, it can cause the sodium levels to go down. And if the patient is also having a heart failure, it can also cause the sodium levels to go down as well. The reason is that there is excess amount of water that is going to dissolve the sodium more. So the concentration of the sodium with fluid overload will go with fluid overload will be low because we have too much water to dissolve um, the sodium. So if low potassium or sodium levels being altered, think more of neurologic and not the cardiac. Next, that also affect the ventricular, that can cause ventricular dysrhythmias is the calcium. So when calcium levels are low, it is called hypocalcemia. When calcium levels are high, it is called hypercalcemia. Now, with any of this, they can also cause the same cardiac dysrhythmias. So major complication, cardiac dysrhythmias. Then um, the other thing that you need to remember is that we can also, in terms of the ST segment, it can shorten the ST segment, but I don't expect that to come from the NCLEX. But what you need to know is that when calcium levels goes up or down, they can cause ventricular problems, and ventricular problems will kill the patient. So they can cause cardiac arrest when potassium levels are too high. Next is magnesium. Magnesium either low. So when you have low magnesium levels, it is called hypomagnesemia. And then also when magnesium levels are low, they can also cause the same cardiac dysrhythmias. It can also cause, sorry, it can cause ventricular dysrhythmias, and this can also cause ventricular fibrillation. So again, we are talking about ventricular problems. So when these magnesium levels are low, think about the heart as well. Now, EKG will also change to show that we have hypomagnesemia, and in this case, you have tall T wave and then the depression of the ST segment. Again, I don't expect NCLEX to be talking about more of this ST segment, but with magnesium, always remember it is the heart that is going to be hit. The other thing is going to be reflexes when it comes to magnesium. So when you have high magnesium level, this can cause the muscles. Remember, high magnesium will cause muscle weakness. It also will cause the blood pressure to drop, and then it also cause bradycardia. So magnesium will do the opposite. So always remember, when magnesium levels goes down up, it will cause the opposite. Blood pressure is going to drop, and then also the patient heart rate is going to drop as well, and then the muscles are going to be more weak, so muscle weakness, and of course the heart is a muscular organ, so that is why everything is going down. Let me talk about the EKG changes again. I'm not going to expect NCLEX to hit you on, but just in case. So EKG changes may be observed with hypermagnesium. So this include when you have your prolonged QR interval and then the QRS complex. But again, what you need to know is that when magnesium levels are high, they cause the opposite, which is going to be muscle weakness. And then when that happens, we can have low heart rate. And when the heart rate is low, it means that the person blood pressure can drop as well. Next of the blood of the labs, which is specific to the cardiac system, is the BUN. It is called blood urea nitrogen. Now, what is blood urea nitrogen? Blood urea nitrogen, we're talking about. Remember, when this you see this in question, the first thing that should come in your mind is a renal problem. So when the person is having kidney issues or renal problems, we expect the BUN to go up. Now, with the BUN, it is not always that we have renal problem. Sometimes when you have high protein diet, you also have cardiac problems, the BUN will go up. And again, when you have liver issues, it can also cause the BUN to go up. But when it comes to renal specific, the lab that we use is called the creatinine. So please take note of this. It's very, very important. Then the blood glucose levels, anytime you have any MI going on or cardiac episode, it can cause the blood glucose levels to go up. So again, when you see that in the questions, um, don't be surprised. So blood glucose, they can ask you to, they can also ask you to evaluate that or check the blood glucose when the person is having a cardiac problem. The next lab I'm going to talk about, which is more also cardiac specific, is the BNP. Now, the BNP is an indication that the person has a heart failure. So when the atrium or the atrials and the ventricles are stretched up, in the case of heart failure, the BNP is released, and it is specific to a heart failure. So high BNP levels, you're talking about heart failure. So again, you are not supposed to know the normal range. So again, when you see that the BNP levels are less than 100, then we say that the person BNP levels are low, but it's normal. But anything greater than 100 is an indicating that the person is having a heart failure. The greater the number, the greater the severity of the heart failure. So heart failure, please remember the lab is BNP. If it is myocardial infarction, it is called troponin. If it is renal, think about creatinine. Let's come to imaging. One of the things that we use in the cardiac system to know if we have cardiac issues is X-ray. So when somebody talk about my chest is paining me, the doctor can order chest X-ray. As a nurse, when it is chest X-ray, make sure that the client is not pregnant before the X-ray is taken. That is what is going to be your safety concern. Another thing is that make sure that they are not wearing any jewelries. Now, when it comes to electrocardiograph, which is the same thing as EKG, this is a non-invasive that we determine if the person is having myocardial infarction or when they're having electrolyte imbalances. So again, it is just a graphical representation of the electrical activity of the heart. So when somebody gets MI, this EKG, it will show on the EKG. Now, but we know that with the labs, it is going to be the troponin level. So when troponin levels goes up, and then the EKG shows that there is an ST elevation, then the doctor will call that myocardial infarction ST elevation MI. Okay. Now, if troponin levels comes and it is low, sorry, if the levels comes up and it is high, and the ST segment is still remains the same or there's no change, that MI is called non ST elevation MI. Don't forget these two. The difference is that yes, the person has MI all right, but the ST did not get elevated. But in case the ST got elevated in case of the STEMI, and if the ST did not get elevated, it is called NSTEMI. So in all of them, the troponin levels is going to go up. So the EKG is not a direct indication that especially when the ST levels remain the same or the segment remain the same or not the same, it's not specific that the person is having MI. What will actually help us know that the person get MI is a lab value, which is going to be the troponin levels. The other lab that I'm going to talk about is the echocardiogram. So when we talk of echo, again, this is a non-invasive procedure and they use ultrasound just to determine whether the structure of the heart. Usually, if there's any structural changes in the heart, especially as blood is flowing, the kind of sound that they'll be producing, the EKG, the echo can pick it up, and then the doctor will say, it looks like we have valve problems, or we have congenital heart disease, or let's say there's a hole in the heart. So this is what would be, so it's just looking at the sound that is being produced when you have the blood flowing through the heart. So the echo will pick it up and then they will start suspecting. So when that happens, we use the echo. So with the echo, there's one thing that you need to know. This is not an invasive procedure, and therefore you don't need to put the person on on the NPO. You don't also need to put to also get informed consent for that. One of the things that you need to know about echo is ejection fraction. So when you talk of ejection fraction, how much amount of blood is pumped when there's one cardiac contraction. In this case, if it is low, then that means that we have problem with perfusion. If it is high, that might be a very good thing, but definitely ejection fraction, if it is low, it tells you that the heart is failing to do its job. The other type of echo is what we call transesophageal. So which means that we go through the esophagus. And so in this case, what happens is that this becomes an invasive procedure. So therefore, the person will have to, you will need to get an informed consent for that. So like I said, this is an invasive exam and requires preparation and make sure that the patient is ready for the procedure. So you need an informed consent. I'm not going to talk much about the stress test, but let me quickly go to, okay, let me talk about the stress test just in case. Now, with the stress test, this is also referred to as a non-invasive test. So again, you do not need um, an informed consent sign for that. But what happens is that the patient will be put on a treadmill, and as they are working out, the doctor will also be monitoring the activity of the heart and see how much stress is being put on the heart when these activities or when you are running or when you as you on a treadmill. So how the heart is responding, the cardiologist will be monitoring that and then will be able to tell. But in case the client is also unable to tolerate this treadmill, the doctor can also infuse a medication. This is the name of the medication, dipyridamole or dibutamin. So when that happens, it goes in to also put the stress on the heart, like you are walking, and so the doctor will be able to also tell the kind of stress that is put on the heart. When that happens, since we are injecting something into the person will have to be NPO before this procedure goes on. So there are two ways to get the stress test done. One, if the person is able to walk, use a treadmill, there's no need for the person to be NPO. But if the person is un unable to tolerate that, then the same thing, the doctor can inject this medication, tibutamin, hydrochloride, into the patient, and it goes to dilate the coronary arteries, and the doctor will be able to get whatever information that they want. In this case, this patient has to be NPO. They need to sign informed consent. So let's look at the pre-procedure for this procedure. The first one is ensure that an informed consent is obtained if the person is going to get the medication injected in the IV. But if they are not and they are just going to use a treadmill, you don't get the informed consent. Encourage adequate rest at night before the patient goes for the procedure. So if they don't sleep enough, then definitely it's going to affect the result because the heart will be pumping. It's just like you have not slept the whole night. So when you wake up, you see that your heart, you might be getting some palpitation. So make sure that the patient had an adequate rest before the night before the procedure. You also want to make sure that if the instruct the client who are having the non-invasive test to eat light meals, so you don't have to put the person on NPO if they are going to get the treadmill. But if they are going to get treadmill, then definitely they are not going to get the treadmill, but they are going to get the IV. Then definitely they have to be NPO. But if it is a treadmill, you don't need to put the person on NPO. Another thing that will actually alter the coronary arteries or the blood vessels, you need to avoid that. So the night before, you need to avoid smoking, alcohol, any caffeine, so the person will not be drinking any caffeinated drinks before the procedure. They have to stop because this all will affect the heart rate. When they come back from the procedure, this is the post procedure. Please instruct the client to avoid taking a hot bath at that time because this can dilate the blood vessels, and when that happens, the patient can get syncope and fall. So for the first 1 to 2 hours, they cannot um, take a hot. When it comes to MRI, please, MRI, always remember this is a non-invasive. They use magnetic to get the images. So always remember the first thing you need to remember is that you evaluate the client for any presence of the pacemakers. They like asking that. Anything that is metallic, anything that is a magnetic material, that magnet can attract it, you need to avoid that. So be careful when it comes to MRI. Now, the difference between MRI and CT is that with CT, the images are going to be captured by X-ray. So X-ray in different dimensions, that is more of the CT. But one thing you know is that when a patient is going, you assess for claustrophobia. So claustrophobia, these are people that are they are more anxious when they find themselves in enclosed spaces. So claustrophobia, either they are going for CT or they are going for MRI, you assess for that. Usually, when they are claustrophobic, we will give them some benzodiazepine, which will help um, with the anxiety. So please take note of this. So either CT or MRI assess for claustrophobic, but with CT, it's X-ray. So the person can have metals in their body um, and still have the X-ray. Anything that is outside, like jewelry, they can come out. But then when they have, if you can have a pacemaker and still get a CT, but you cannot have a pacemaker and go for this MRI. I hope that is very clear. So just take note of that. You can pause over here and then take a little break. But after that, you come down and you'll be getting the cardiac catheterization. Now, with cardiac cath, you'll be hearing, oh, the person is taken to the cardiac lab. So catheterization, remember, it's cardiac. So this is where a catheter is going to go into the heart. And this will help evaluate if we have any clot or abnormalities in the blood vessel, the coronary arteries or the coronary blood vessels. So again, this is an invasive test, and this involves insertion of the catheter into the heart and the surrounding blood vessels. So you have to obtain an informed consent before this patient goes for that. You also, the main reason why we also do the cardiac catheterization is that it helps us obtain information about the structure and performance of the heart chambers. And so when something is not right, the cardiac catheterization will help us identify that. Either it's a valve problems or there is a blockage in the coronary arteries. So when there's a clot over there, with the cardiac lab, they're able to figure out and also take care of that or find out what to do. So how do you prepare somebody for the cardiac lab? One, you make sure that you ensure that an informed consent is being signed because this is an invasive procedure. Again, with a cardiac lab, they will always be injecting a dye. And so you will need to assess for allergies to the seafood, iodine, or radio opaque. If the person is allergic to the dye, it doesn't mean that they will not be able to carry out with the procedure. Anytime somebody is allergic to something, as a nurse, you need to ask what happens when you are exposed to that. If it is just itching or it's just, let's say, some kind of hives, that can still go ahead and pre-medicate the person with antihistamine, or they will put the person on steroids, and so that the person will not react to the dye. But after the procedure, you still be monitoring the patient for these reactions. You also have to put the person on NPO as well for this procedure. And also, the reason we do that is that we want to avoid or prevent aspiration during this procedure or vomiting. You want to also document, this is not a major thing, but to determine the amount of dye that needs to be injected into the person in the cardiac lab, you need to know the height and weight. So please take note of that. This will determine the amount of dye that needed to be used to carry out with the procedure. So when both of us are taken to the cath lab, the amount of dye that will be injected in both of us will not be the same because our height and weight are not the same. Then with cardiac lab, you always, when they come back, you always want to be monitoring their vital signs and then the presence of the peripheral pulses. The main thing is that anytime they come back, vital signs are going to be your major problem. Now, the reason is that we are using an artery, and therefore, when they come back, you are thinking about bleeding. So, our major thing or priority is going to be checking for bleeding because an artery is involved, and so they can put them in at risk of bleeding easily. So, again, the insertion site before they go in for the procedure, you need to shave that infection, the insertion site. You clean it with antiseptic solution before they go in for the procedure. And again, when they go, they will clean that area as well. The reason is that we are going straight into the heart. So when we introduce any bacterials in there, we can have what I call it. The person can go into septic. So you don't want that. One of the things that I've seen that NCLEX love a lot is that if the person is diabetic and they are on metformin, you need to hold the metformin at least 24 hours before they go in for the procedure because it put them at risk of developing what we call lactic acidosis. Please take note of this. Metformin, anytime you are having a dye procedure, you need to hold metformin because of lactic acidosis. Now, after they come back, you don't resume the metformin right away. It has to be at least 48 hours after the procedure before you actually ever give the person or resume um, the metformin. Now, when they come back, this is where NCLEX also love to ask a lot of questions post procedure. The first thing you need to know is that since an artery was involved, you need to make sure that you are checking the peripheral pulses, especially if they go to the arm, you check the pulses below, around the finger areas, so that just to make sure that we have enough circulation, they didn't mess up with the artery. In the patient, you monitor for the peripheral pulses. You also be looking for the color, warmth, and also sensations. So if the person comes back and then they start complaining of numbness and tingling, it's a sign that this person is having problem with circulation, and you need to inform the provider right away. Again, if you notice that the side below the insection side is becoming pale, it's a sign that we're not getting enough oxygen, or when it is cold, it's a sign that this person is not getting enough blood to that area. So please, this take note of that. Now, so like I said, anytime you notify the healthcare provider when you have numbness and tingling is very important. When the extremities become cold, cyanotic, which is the bluish coloration below the site, is telling you that the site is lacking oxygen. If care is not taken after cyanosis, first it will start with cold, it goes pale, so the place will become more pallor or white. Then, if care is not taken, it then start turning into blue, and then it will go into necrosis or it becomes necrotic. So please take note of this. It's very important. And so when they come back and you are checking the peripheral pulses and they are not there, it's a sign that now there is a problem with the circulation. Something is not right in the arteries, the coronary arteries, and you need to um, involve the provider right away. So when they come back, the main thing you should be looking for is going to be bleeding. And like I said, always remember, um, check the patient vitals. If you see that any abnormal vital signs, you notify the provider right away. You also want to know if they went into which side that is being used. So in this case, they can use the femoral. So this is the femoral. So when they go up here, or when they use the femoral, when they come back, please, they like asking these questions a lot. When they come back, you want to make sure that you maintain strict bed rest for at least the first 6 to 12 hours. Then also, do not elevate the head of the bed no more than 15 degrees. So remember this. They like asking that. So when they come back and then you put them in a high follow position, it is contraindicated after the patient returns from the cath lab. It is not um, 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 it is not indicated, or it's not something you have to do, especially when they use the femoral. Now, if they use the anti-cubital or anti-cubital, then of course they can raise the head of the bed. But with this one, if it is happening in the arm, this is the anti-cubical, you need to give them an arm board to straighten the arm so that they don't bend and cause any hematoma or occlusion around the catheter site, the catheter insertion site. And then because the dye is involved, another thing you need to do is to encourage fluid intake to get rid of the dye. Then also make sure that you replace the fluid loss as quick as possible because of the dye. So you'll be drinking a lot. You encourage fluid intake so that you can get rid of the dye. So how do you know if the patient is having problems with the dye? So you monitor for nausea, vomiting, any rash. It's a sign that the person is reacting to the dye, and you need to inform the provider right away. So that brings us to the end of the diagnostic test procedures that you need to know as far as the cardiac is concerned. All right. If you have any questions, please let me know. So you can see that this is a catheter that is inserted into the heart. We want to know if there's any abnormalities that is going on in the heart chambers. If it is, it will show it up, either the valve, either the ventricles, either the atrium, the arteries. The atrium, it will bring it out. So the cath lab is very, very important. They like asking questions over there. Okay, let's come to our cardiac diseases now. This is where I want you to pay attention. So, the diseases, the first one I'm going to talk about is coronary artery disease. So, when of coronary artery disease, please again, let's go back to our heart. So, coronary artery disease, we're talking about this area. The arteries over here. So coronary artery disease, when you have buildup of cholesterol, that's atherosclerosis or something happening and you have spasms, uh, there's a narrowing of the coronary arteries. Anything that can cause or that will prevent the flow of blood in the or that affect the flow of blood in the coronary arteries, we are referred to it as coronary artery disease. So now let's look at what we have here. Our coronary artery disease. Oh, let's see here. So coronary artery disease, always remember the narrowing or obstruction of one or more of the coronary arteries as a result of atherosclerosis. So by now you know what atherosclerosis is, which is accumulation of lipid-containing plaque in the arteries. This will prevent or decrease perfusion, and most of the time is going to cause either myocardial tissue damage or we have less oxygen going to the heart muscles. In this case, we'll be having angina. When there is a complete blockage of the heart muscles, complete blockage where the heart muscles are not getting oxygen, it will cause a cardiac infarction. On the other hand, if you have too many of the myocardial infarction and it can affect the pumping ability of the heart. And that's what we call a heart failure. When you have too much of this going on, either myocardial infarction and then you have a heart failure, then you can also get what we call cardiogenic shock as a result of that. This patient can die. So know the difference. There's one thing you need to know is that the coronary artery disease is not the one that's going to kill the patient. It is the complication, the MI, the heart failure, the angina. Those are the things that you should be thinking about. So mostly the coronary artery disease is a precursor for all these problems that we are talking about. So when somebody is having coronary artery disease, where there is obstruction to the flow of blood, some of the assessment, what are some of the things that you will be talking about, you should be expecting from the patient? One, you'll be having the patient will be complaining of a chest pain. So when the person is having a heart failure, you expect them to have a chest pain. You expect them when they are having MI, there's going to be a chest pain as well. You also when it is angina, there's going to be a chest pain. So chest pain is not very specific to either MI, heart failure, angina. So when the person complains of a chest pain, the first thing you ask yourself is, okay, it could be angina, it could be MI, it could be a heart failure, but how do I differentiate all this? One of the things is you go into the lab. If the patient complains of a chest pain, and then the lab comes out and troponin levels are high, and it's MI. If troponin levels are low or they are normal and nothing happens to troponin, you know that it's not MI. It's likely to be angina. Then we could talk about palpitations of the heart. We did talk about dyspnea, which is difficulty breathing. Syncope, this is where the person have a sudden loss of consciousness, or when the heart rate gets dropped all of a sudden, and then they lose consciousness and fall. Sometimes they don't have to fall; they become more dizzy, and that is syncope. Then there can also be coughing and hemoptysis. So that is where the person is coughing out blood, and then they can have excessive fatigue. So all these things will show up in any of these cardiac problems. So because this is coming from the coronary artery disease. So coronary artery disease can result in any of this. So just make note of that. So what are some of the interventions? How do we prevent these complications from happening? One of them is you want to, if they are diabetic, you want to what? To put them on low calorie diet. You need to control their blood sugars. Then sodium, you need to put them on low sodium diet because of the hypertension. So please take note of that because myocardial oxygen demand can cause the blood pressure to go up. And so please take note of that. You need to put them on low sodium diet. You need to put them on low cholesterol diet to prevent the atherosclerosis. And then also you put them on low fat diet. Now, these are things that you need to know. And again, you do not want to put too much stress on the heart. So you want to also give them fiber so that it will prevent constipation and not go in and be straining when you want to poop. Another thing that you need to know is stress. Stress will cause all the release of these neurotransmitters, and therefore be careful. You have to find a way to control your stress level. Very, very important. And then I already talked about glucose control. And also you need to increase exercise and to or activities that will help make sure that cholesterols are not building up there. When it comes to medication, the major medications that we're going to be talking about are nitrates. So nitrate, the most common one we're going to talk about is nitroglycerin. Nitroglycerin is used to dilate the blood vessels, and one of the common side effects about the nitrate is going to be headache. Calcium channel blockers, we know that will also dilate the coronary arteries and help reduce the spasms. So if it is a spasms and the doctor wants to prevent the spasms in the coronary arteries, you put them on the calcium channel blockers. We'll talk a lot about calcium channel blockers very soon. Then again, you want to put them on cholesterol lowering medication. We're talking about Lipitor. This will help lower the cholesterol. Then we put them on beta blockers to control the blood pressures as well. So these are things that you need to know about coronary artery disease. Again, coronary artery disease is not the one that's going to kill the patient. We want to prevent the complications. And the complications are number one, angina. So when we talk about angina, what is angina? Angina is just a chest pain as a result of low oxygen going to the myocardial cells because of ischemia or because the coronary arteries are being narrowed. There are so many things that can cause this. One of them is CAD, which is coronary artery disease, where there's a buildup of cholesterol in the when there's a buildup of cholesterol in the coronary arteries. So the person is not getting enough oxygen, and therefore the person will be complaining of a chest pain. Now, in this case, there is no complete blockage, so we don't expect myocardial cells to die. So, and therefore, troponin levels will never go up in case of angina. Because of the narrowing, we need to dilate. So, anything that is going to dilate the blood vessel or the coronary arteries would be a very good option to help control this. So the major cause is coronary blood flow, that's obstruction to the coronary blood flow, and one of them is atherosclerosis, and then also coronary artery spasms. So when it is spasms, we have to use the calcium channel blockers to stop the spasms. And when there is an increase in myocardial oxygen demand, this can also cause the angina. And therefore, there are two major types of angina. So one of them is called stable angina. I'm not telling you about two types, but mostly the angina, when you talk of stable angina, it means that you can predict what is causing the chest pain. So in this case, for example, if I'm going to mow the lungs and I know that my oxygen demand is going to increase, and I take my nitroglycerin to dilate the blood vessels, I can mow the lungs without having any chest pain. So this occurs with activities that involve in exertion or emotional stress. So when you get rest or you are able to control your stress level, or you take nitroglycerin and then this chest pain stop, it is more of stable. So you can predict what is causing it and then you can put interventions in place. The other type of angina is what we call the unstable angina. So this one, it can occur. You cannot predict that. So even when you are at rest, it can still occur. This can be as a result of spasms that is going on in the heart. So definitely, what happens is that this occurs. It is unpredictable, and also the degree of exertion or emotion increases in the occurrence. So again, the duration of this chest pain is also longer, and it is more severe as time goes on. Now, this pain, it will not be relieved by rest or nitroglycerin. So in this case, our drug of choice is going to be morphine sulfate to help dilate the blood vessels, and also because it's an opioid, it can take care of the pain as well. So when the person takes the first nitro and it's not working, you should be preparing to give the second one, but you call it 911, but you cannot give more than three. And you'll be giving in between 3 to 5 minute intervals for the chest pain for nitro. Yeah, for chest pain if it is related to angina. But remember, when it is an unstable angina, remember that the nitroglycerin will not be able to control the pain. Now we also have the last type of angina, which is called the variant angina or transmittal angina or uh, vasospastic angina. So again, this results in coronary arteries when they are having spasms. Uh, this can occur when the person is at rest, and then again, TAC may be associated with ST segment elevation on the EKG. So anytime somebody is having a chest pain, one of the things that the doctor will order is an EKG. Want to know. So when it is an angina, you don't expect troponin levels to go up because the cells are still intact. They are not being damaged. But if it is going to be what do you call it? If it is not myocardial infarction, but when it is angina, for angina, the troponin levels will remain the same. If it is myocardial infarction, yes, then we expect troponin levels to go up. So let's look at assessment. The assessment, we talk about pain. When the person complains of a chest pain, one, this pain can be developed very slowly or it can come quickly, depending on the kind of angina that the person is having. Now, they may describe the pain as mild or moderate, and sometimes they will describe it as substernal crushing or squeezing in the chest, and the pain may radiate to the shoulders. So, if it is related to the cardiac, the pain will be moving through the shoulders, to the arm, to the jaw, and to the back. That is more of a cardiac problem. So, when the person complains of a chest pain, and then they tell you that the pain is radiating to the jaw, the pain is radiating to the neck. Think about any of these cardiac problems. They can cause that. Either angina, myocardial infarction, cardiogenic shock, any of them can cause that. And so you have to be thinking about all the cardiac um, tests that we talked about. So do not miss them. Now, if it is also cardiac related, when the patient tells you that they are having more of epigastric pain or heart burns, and the pain is not moving to any part of the body, it might be related to more of a GI and not cardiac related. Then how do we also, if it's not the lungs? Now, if it is the lungs, then inspiration and expiration will increase the pain intensity. But to avoid or to rule out the respiratory system, you are also going to be looking at the intensity of the pain if it is being affected by inspiration or expiration. Now, if it is affected by inspiration or expiration, then it is not about cardiac problem, it is more of a respiratory problem. So with the cardiac problem, inspiration and expiration does not affect the intensity of the pain. And so that's why we always want to ask a patient when they talk about chest pain. We ask them, is the pain moving to any part of the body? Ask them to describe the pain. Is it crashing? Is it substernal? Or ask them if the pain is moving to the arm, to the jaw, to the neck. And if it is being affected by inspiration or expiration, if that happens, you want to rule out is it a respiratory problem or is it a cardiac problem. Now, the pain will usually last between 5 minutes. However, this pain can also go up to 15 to 30 minutes. Again, pain when it is a stable angina, the pain may be released by nitroglycerin. But if it is not a stable one, you need to get morphine sulfate. So in nursing school, you were taught about MONA. MONA, which stands for morphine sulfate. We talk about nitroglycerin. We talk about giving oxygen and then giving analgesics, which is pain controls. So now let's talk about dyspnea. So again, this is having somebody is having a chest pain, so it's being related. The patient will be having difficulty breathing. Remember, oxygen is not moving to any parts of the body the way we have to get. So you'll be checking for pallor, which is pale, and then also sweating. Diaphoresis is a major thing that you see, especially when the person is having MI. Then they will talk about palpitations, which you know by now, and then tachycardia, which refers to an increase in the heart rate. Now, the person can also be dizzy and also be having syncope. Remember, the person is having cardiac problems. The ventricles are not able to pump the way they have to pump, and therefore there's going to be a decrease um, in the circulation of the oxygenated blood, and this can cause syncope and also when there's a sudden drop in the heart in the rate or there's a sudden drop in the blood pressure, it can cause syncope as well. All right. So let's talk about hypertension. So blood pressure can go up and also it can cause GI disturbances. So what do we do? What are some of the things that we can do to help this patient? Intervention. Now, we need to make sure that the patient is being put on low cholesterol diet. Anything that we did talk about coronary artery disease, it can be used to help patient with angina. The interventions are the same for all the cardiac problems. So put them on low cholesterol diet, maintain ideal body weight. You want to control their blood sugars as well. The medications, we already talked about them. We talk about the nitrate. The nitrates are the nitroglycerin. And then for long-term use, we use the isosabide nitrate. Remember, the key thing is nitrate. Nitrate will dilate the blood vessels. The most common side effect of the nitrate is going to be headache. So when you see that, it's not anything that you should be worried about. It's an expected side effect of the nitrate. The calcium channel blockers usually will stop spasms if it is being caused the narrowing of the blood vessels or coronary blood vessels is cause of spasms. Then the calcium channel blockers will stop the spasm and also help dilate the blood vessel. The most common one that we use are the thiazine and verapamil hydrochloride. So please take note of your first two calcium channel blockers that are used in controlling angina. Pison, verapamil, these are the two things. They will dilate the blood vessels and also coronary artery blood vessels and also stop the spasm. Now, when it comes to the blockage, when it is a clot that is causing the obstruction, sometimes the doctor will use the thrombolytics. So thrombolytics is going to dissolve the clot. There are two different things. There's a difference between thrombolytic and anticoagulants. The anticoagulant will prevent clot from forming, and the two major anticoagulants we did talk about are the heparin and also the warfarin. In terms of thrombolytics, they dissolve the clot. So if the blockage or if the obstruction is because we have a clot over there, the doctor will order a thrombolytic. The common one that we have there is called the TPA. So take note of that as well. So those of you who work in the hospital, you see that if the patient has a PICC line or they have um what's the name? They have a PICC line, they have a port, and the port is not drawing, and we suspect that there's a clot in any of this that's preventing the blood return. The doctor will order a flow. So this will go and dissolve everything in there, and then you can get your blood returns easy. The other thing is we need to control pain. And like I said, if nitroglycerin doesn't work, then of course we have to use morphine. So morphine sulfate is the most common that one that we use in controlling the pain. So morphine again is going to take care of the pain. It also help dilate the blood vessels. So again, when you're giving morphine, make sure that their blood pressure is stable before you give them the morphine. Medical side, medical aspect, the doctor is going to put a stent in. And when we talk of stent, this is where the doctor will go into the blood vessels and put a stent over there uh, and open the blood vessels. So, and the other one we talk about is called coronary artery bypass graft. So when we come to class, I'll show you videos of what coronary artery bypass graft is and then also what a stent is. Do you have any questions about myocardial infarctions? Please write them down before you come to class. Oh, sorry, that's angina. So we know what angina is now, and then how to control and the medications that are involved. Next, let's talk about myocardial infarction. So when we talk about myocardial infarction, we are referring to what? Myocardial infarction, we are going into where this time around the complete blockage of oxygen that is reaching to any part of the heart. So in this case, cells are beginning to die. And again, when that happens, what is going to happen is that troponin levels are going to go up. And we say that the person has myocardial infarction. So MI occurs when myocardial tissues is abruptly or severely deprived of oxygen. Not all clients will be experiencing the typical symptoms of myocardial infarctions. And what are they? These are the people that will be complaining of a chest pain. They'll be saying that chest is crushing. Not everybody will be complaining of that, especially women. Women, they will not be complaining of a chest pain, but they will be talking about discomfort, shortness of breath, or fatigue. And often the ST segment will never be elevated when you get the EKG. And so they will have the N-STEMI, which you know by now, that it means that when EKG was taken, when the person was complaining of a chest pain, the ST segment came unchanged. So the ST segment was still stable. But the labs showed that the person troponin levels went up, and therefore we say that the person is having myocardial infarction, but then the elevation, the ST segment of the EKG did not get elevated, and so we call it NSTEMI. With older adults, what happens is that they don't also complain of the chest pain. They'll be having shortness of breath as well. And also, sometimes they'll have pulmonary edema. So when you have pulmonary edema, we're talking about the lungs. This is what will be they will be experiencing. And then again, they'll be having dizziness and altered mental status, delirium. So this is where the person goes into psychotic mode for some time and then they get out of it. So when you have a patient that comes, especially the adult, the older clients, and then they come and the doctor decides to order troponin levels, you should understand that. But you say that how, this person is not complaining of a chest pain. How come you are asking me to check the troponin levels? With older clients, like I said, they may not experience the normal chest pain, but they will also be experiencing shortness of breath, dizziness, and altered mental status. So the doctor will order that. So when they are also having delirium, it's also might also tell us that the person is having myocardial infarction. With diabetic patients, they because if we did not control their blood glucose for too long, they can have neuropathy, and as a result of that, they lose all the sensation. So they might not even know, or they might not complain of a chest pain at all. They are more going to be asymptomatic. So the only time that we know that a diabetic patient might have a myocardial infarction is when the lab comes out and it shows that the troponin levels goes up. So not every client is going to show that they are having a chest pain so that for you to know that, oh, this person is getting MI. So at least by now you know what MI is. You know that diabetic patients will not be showing the symptoms that we did talk about, the chest pain radiating to the jaw, radiating to the neck, radiating to um, other parts of the body. So then let's look at some of the risk factors. So when talking about the risk factors, this is what NCLEX is going to test you on the risk reduction aspect. So the risk factors to prevent myocardial infarctions are one, you talk about atherosclerosis, we know that word now, and then this results in CAD. So atherosclerosis will go into CAD, so coronary artery disease. And again, when you have elevated cholesterol levels, we need to control the cholesterol. All these things are all related. Then smoking, please. Smoking is will constrict the blood vessels, and we don't want that to happen. We want to dilate the blood vessels. That's why smoking cessation is very, very important when it comes to the cardiac. Then hypertension, we need to control the blood pressures. We need obesity, we need to control the weight, and also physical inactivity. The person is not exercising. I doubt how many of us exercise. And also, when a person is diabetic, make sure that you control their glucose levels. If not, they can easily get a myocardial infarction. And then also stress, very, very important. So with MI, what are the things that we're going to be talking about? The diagnostic studies. We did the first thing we talk about is going to be EKG. In this case, the ST segment will either get elevated or will not be elevated at all. But remember, we talked about the labs, the troponin levels will go up. The creatinine kinase will also go up as well. Then we also have myoglobin levels that will also go up. And then the white blood cells, we know now that white blood cells will go up. But in this case, temperature will remain the same. So this is the ST segment that I'm talking about. The normal, this in EKG, this is going to be your P wave when the atrials are contracting. And then these are the QRS. So the QRS, always remember, this is the QRS. QRS is going to be the ventricles. So when this is the atrial, this is the ventricles, and this is the T wave. So we have the T wave. So when you have the ST segment elevated, you can see that this is QRS and this is the T. So when the ST segment is elevated, this is what you see on the EKG. And when the ST segment is depressed, this is what you see. So our diagnosis test that we're talking about. So the first thing, think about now, so after the person get MRI, sometimes the doctor will see, okay, let's see what kind of stress is being put on the heart with myocardial infarction. Again, the doctor will order what we call the exercise tolerance or the stress test, which we did talk about before. So the stress test, we said that the person will be on a treadmill, and then the doctor will be evaluating the activities of the heart. So exercise tolerance test or stress test is assessed for electrocardiographic changes and ischemia, and to evaluate medical therapy to identify clients who may need an invasive therapy. So sometimes we don't just jump into going into the cardiac lab. The doctor can rule out some things easy. One of the things that the doctor can do is what called the thallium scan to assess if we have any ischemia or when there is any tissues damage. So when it is necrotic, for MI, it can pick it up easily. So thallium scan is one of them. Then the other one, which is more invasive, is the cardiac catheterization. So this will know exactly how to prepare the patient from going to the cardiac lab, and when they come back, we also know what to do with the patient. So with myocardial infarction, what are the assessment? Again, this as the angina, we have pain. Yes, the client will still be complaining of pain. That's a typical one. And then the client be experiencing the crushing substernal pain. So you notice that these same symptoms is what the patient with angina is facing. Again, when the pain is radiating to the jaw, to the back, or to the left arm, it's more of an indication of an MI. Again, with angina, the patient will also have the pain radiating to the jaw and to the arm. So take note of this. It's very, very important. So when you start reading the questions and then they start complaining of chest pain radiating to the jaw, think about what diagnosis you should be thinking about. Is it going to be MI? It's going to be angina? It's going to be acute heart failure? It's going to be cardiogenic shock? Anything. So please take note of this. Pain may occur without any cause. Primarily, it can occur early in the morning, and then pain will not be relieved by nitroglycerin. So, if the patient is complaining of a chest pain, and then you give them the nitroglycerin, it didn't relieve it. There are two things. You know that no, um, this is not stable angina. It might be like unstable angina, and at the same time, pain, if nitroglycerin does not do the job, then you have to give them the morphine sulfate, which is an opioid. But in the case of MI, the pain will last longer, usually about 30 minutes or longer. Think about nausea, vomiting. The patient is having diaphoresis. That's when they are sweating profusely. So when you're reading the question, the patient complaining of a chest pain, they are diaphoretic. Think about MI. Think about dyspnea. These are the same things that we saw in angina. You can see that. So the person will be more feeling like fear, and then or they will be more afraid, and then anxiety will set in. Now, because the heart is not pumping the way it's supposed to pump, you assess for pallor, which is the complications of the heart failure. Again, perfusion. So pallor, cyanosis, coolness of the extremities. So again, what are some of the interventions that we can put in place? These questions are going to be on the physiological aspect, the intervention that we put in place for somebody who is having MR. The first thing is we need to control the pain. So again, we give them morphine sulfate for MI. If you identify that it's MI, it is not nitroglycerin, but we give them morphine sulfate. Now, if we give them morphine, then we also have to give them the oxygen. But then, when the person is in pain, the demand of oxygen is going to go up. So, we need to control the pain first before we think about giving the person oxygen. So, once we control the pain, we give the person oxygen. We also put the patient on a cardiac monitor as well. You will be assessing the respiratory rate, the breath sounds because the person can be dyspneic, and then also you assess for signs of a heart failure. Because if you have multiple MI, the contraction of the heart is going to go down, and therefore the person will it can lead to heart failure. So you'll be assessing for any signs of a heart failure as well. And how do you know? One of the signs that I'm going to talk about when it comes to heart failure, especially when your left sided is failed, the fluid, there's going to be a buildup of fluid, especially blood will be built up in the lungs because the left side of the heart actually receive its blood from um, the blood from the pulmonary system. And so when that happens, there is going to be a backflow of the blood to go to the lungs. And when there's a fluid building up in the lungs and you auscultate them, you hear crackles and also um, you hear crackles most of the time. And when you can also hear wheezes or dependent edema, when if it is the right side of if it's the right side of the heart, you see that the person will be having edema in the extremities. But heart failure, you can get crackles, you can get edema. Those are the things that I want you to know for the NCLEX. So when the person is having myocardial infarction, again, we want to make sure that the person's oxygen demand will not be increased, and therefore you want to ensure that there is bed rest. You place the client in a semi-fowler position so that the lungs can easily be expanded and you can get more oxygen. So please take note of this. It's very, very important. Oxygen, oxygen, oxygen. Anytime you have a patient that is having myocardial infarction or you suspect them having MI, you always want to stay with them at all time. You will be getting an EKG as well. So when the question talk about select all that apply, these are all things that you can do for the patient. You get an EKG, you also get the person to be on bed rest, you elevate the head of the bed, you want to do anything that you can to help with the oxygenation. So everything that we're talking about is perfusion. We want to get the heart needs now more oxygen because of this infraction, or so definitely any of the intervention that will increase oxygenation will help. Then again, we will be monitoring their labs, and the main lab that we're going to be monitoring is going to be troponin levels. And then we also know that when troponin levels goes up, this person is at risk of developing clot. So these are things that we need to know. You see that the patient will be put on anticoagulants. Let's look at treatment. So when it comes to the medication aspect, oxygen. So prepare to give oxygen, nitroglycerin, if it is because there's a narrowing and because the person has angina that is going up, so we can give that. Beta blockers. But with MI, the first thing is going to be more of your morphine. Very, very important. If it's a clot, think about thrombolytics. They go in and break the clot. And we do that by taking the person to the cardiac lab. And so they will be having cardiac catheterization. We did spend a lot of time with cardiac catheterization. The other one is the standard percutaneous coronary intervention, which is called PCR. This usually happens within 90 minutes. So if within 90 minutes the patient is complaining of a chest pain and it's because of a clot, the first thing is that they within the 90 minutes, if they are able to break the clot, it will prevent or reverse the effect of the damage. But after the 90 minutes, there's nothing you can do. The muscles are dead and they're dead. Then presentation or what do you call it? Stent placement is one of them that we have to do, especially when there is a damage, when there is a buildup of cholesterol, or when the coronary blood vessels are narrowed, the doctor will put in a stent. Then we did talk about coronary artery bypass. And like I said, we'll be watching videos on that. You can also Google that or go to YouTube and Google coronary artery bypass, and you know what I'm talking about. Then anything that the client can do to prevent all these things from happening, you want to teach them that. It is very, very important you let them know. Now let's come to our next problem, which is the heart failure. So when talk about heart failure, I've already talked about that. The heart is not able to pump. The heart is not able to pump the way it's supposed to pump to get oxygen to all parts of the body. So when the pumping ability of the heart goes down, then that's what we call a heart failure. Now, when that happens, this is what is going to happen. There is going to be a diminished cardiac output, and there is going to be less oxygen going to the peripheral. That's the fingers and other stuff. So when that happens, we say that the person is having a heart failure. But the main thing is that when we have a heart failure, there are two things you need to remember. The first one, always remember, it can be a left-sided heart failure or a right-sided heart failure. This is what NCLEX can hit you on. You need to know the difference between a left-sided heart failure and a right-sided heart failure. Now, you don't have to memorize this. All you need to know is that with the right-sided heart failure, know that the right side of the heart is the one that receives blood from all parts of the body, and then it takes it to the lungs for oxygenation to take place. So when you have a right-sided heart failure, and it means that the right side of the ventricles is not pumping to take the blood to, it's not pumping to take the blood to the lungs, oxygenation. When that fails, any blood that is coming from any parts of the body, especially the legs, from the head, they will not be able to come because the heart is not pumping. So what happens is that they will stay at where they are. So with a right-sided heart failure, think about systemic problem. Edema is going to be the swelling is going to be in the system. So with a right-sided heart failure, think about the legs. Think about the kidneys, they will be inflamed. Think about the liver. The liver will be inflamed because all these things will have to bring the blood to the right side of the heart. But here's the case, the right side of the heart fails. So wherever this blood is coming from or the fluid is coming from, they will not have any place to go. And therefore, what happens is that you have edema. So you will be having what we call acute with the right side of the heart. Always remember you'll be having systemic yes, you'll be having dependent edema. So always remember that. So the legs will be swollen, then blood coming from the head is coming from which should be in the vein. So think about the venous problem. So we have a jugular vein distension. So again, abdominal distension because the liver will not be able to bring its blood to the right side of the heart. So you're having a liver failure. So in this case, the doctor will be ordering labs for liver failure. So to monitor liver failure, you'll be talking about ALT, AST, bilirubin, and also albumin levels. Now, with a heart failure, this is where we have what we call hepatomegaly. So please take note of this. With hepatomegaly, that is the heart, the liver being inflamed. So the liver function test will be ordered when it is a right-sided heart failure. So in this case, the lab that you should be monitoring for liver function test is going to be albumin, is going to be ALT, is going to be AST, is going to be bilirubin. There is only one of these lab values that is going to go down, and that is going to be the albumin. The rest will go up. Then again, the spleen will not also be able to retain its fluid, so we have what called splenomegaly. And then because the patient is retaining all the fluid, they will have weight gain, and the person will not be having, in terms of GI, there will be more of a nausea and anorexia. Then we also have what we call nocturnal diuresis. Noc means night, diuresis means peeing. So they'll be waking in the middle of the night to be peeing a lot. Then we have what we call swelling of the fingers and the hands. Remember, it's the right side, so it's systemic swelling. And then if they have a liver failure, they might also be getting what we call ascites, where their belly get bigger and bigger and bigger. So to bring the fluid out, we use what we call paracentesis to bring the fluid out. So in this case, with a heart failure, the lab that we should be looking, oh no, the blood pressure will be more of what? Will be either the blood pressure will go up or the blood pressure will go down. Now, if the blood pressure goes down, then that means that the heart is not pumping. So if it's a pumping thing, the heart is not able to pump, so the pressure is going to be low. At the same time, if the pressure is high, it means that there is buildup of fluid in the blood vessels. So that is what is causing the pressure to go up. So with heart failure, either the left-sided or right-sided, the blood pressure will remain it will either go up or will go down. So if it is a pumping problem, the blood pressure will drop. And if it is not a pumping problem and there's a fluid overload, then the blood pressure is going to go up. In terms of the findings, the laboratory findings for the right-sided failure is going to be more of a liver function test, and with liver function test, it will show us the ALT, AST, bilirubin, albumin. Again, among these labs, it is only the albumin that goes down. The rest, the rest will go up. Then the BUN and the creatinine, they will show if we have problem with our kidney. So Please take note of that. On the other hand, when we have a left-sided heart failure, the left side, the blood is being received from the lungs. So if the left side fails, then it means that the congestion is going to be in the lungs. So the person will be showing a respiratory symptoms. So this time around, the edema is going to be in the lungs, and therefore the person will show respiratory symptoms. What are they? These are dyspnea, difficulty breathing, dyspnea, increase in the respiratory rate, and crackles. So when you listen to their lungs, you hear crackles. We have dry, hacking cough. So you see that these are all respiratory problems. Then we have at night difficulties breathing, especially at night. And again, the blood pressure will either go up or go down with a left-sided heart failure. So please know the difference between a left-sided heart failure and a right-sided heart failure. So when it comes to the lab for the left-sided heart failure, because it is a respiratory problem, the doctor it will be ordering what we call ABGs. And we have already talked a lot about ABGs. And so ABGs will tell us if how much oxygen is being dissolved in the blood and how much carbon dioxide is also in there. So again, left side of the heart, labs, think about ABGs. With an X-ray, the doctor can order an X-ray to show if there is any congestion or fluid buildup in the lungs as well. The doctor can do that. Then the other lab, which will tell us whether it is left side or right side, it doesn't matter, is the BNP. We know what the BNP is for now. So let's look at medications. So in terms of medications with the heart failure, think about diuretics. So diuretics, the major common one is furosemide. The person has to pee all the fluid out so that the lungs will be cleared and then the legs will also be less swollen now. So think about heart failure, our first medication, furosemide, which is a diuretic. And then we also have this is the major one that they use. This sometimes they also be you might see this medication in there. But one of the things that you need to know is that if it is furosemide, you need to know that no, the patient's kidneys are functioning well before you give them this medication. If not, the person cannot pee. And so furosemide, please take note of this. Because it's a heart failure, if it is a pumping problem, we need to put the person on digoxins. I did mention about digoxin that you need to always make sure that the heart rate is being checked and it's for 1 full minute. And with that, always remember anything less than 60, you need to hold the medication and question the patient and clarify with the provider. With digoxin, always remember when potassium levels are low, it causes digoxin toxicity. It put the person at risk of getting digoxin toxicity. Now, with the tachycardia or with the heart failures, we also use the carvedilol. So when the person is having a heart failure, the doctor will order carvedilol or metoprolol. These are called beta blockers. Then with blood pressure control, we use lisinopril. Those are called ACE inhibitors. Now, if the person is having a heart failure, remember the heart is not pumping the way it's supposed to be pumping, then definitely the chances that blood can clot is very, very high. And since a heart failure is a chronic condition, the doctor will put the person on warfarin. And again, we talked a lot about warfarin, so now you know why I put so much emphasis on the warfarin. So, what are some of the things that we can do with somebody with a heart failure? Oxygen is going to be one of our major things that we have to consider because this person is having problem with circulation, perfusion. So you give the person oxygen. In terms of health promotion, we also make sure that we educate them on low sodium diet and also fluid restrictions. Remember, that's the main thing. They cannot pump the distance. So we put the person on furosemide to diurese the patient. And so when that is happening, you also want to restrict fluids as well. You have to let them avoid alcohol. Remember, the person is having a heart failure. The kidneys, the liver is already in trouble. There's too much pressure on the liver, and therefore you have to avoid this alcohol, anything that will put too much pressure on the liver. Then we also want to lower cholesterol as well, because we have these cholesterol lowering medications. We don't want to get the person to have too much of this cholesterol buildup in the coronary arteries, which can cause myocardial infarction and also result in heart failure. So let's talk about acute pulmonary edema. So when the pulmonary edema, because we have the heart failure and fluid is now built in the lungs, the patient will be having dyspnea, difficulty breathing, tachycardia. There will be an increased heart rate, and in tachypnea, there will be an increase the um, in the respiratory or difficulty, yeah, increase in the respiratory rate. So, and then the person will be having nasal flaring. Remember, this time the congestion is in the lungs or the respiratory system. So remember, they will have nasal flaring, and then also the use of the accessory muscle. Then they might be having crackles when you listen to them, and wheezes as well, and also when you auscultate them. Sometimes you'll be hearing a gargling respirations as well. It's a sign that the patient is having fluid buildup in the pulmonary system. When they cough, sometimes they will be coughing blood. Remember, because of the congestions. So always remember this. They might be coughing out blood as well, or they might be getting sputums, and with this sputum, they are more frothy sputum. Then again, because they are lacking oxygen, they'll be more anxious, and then also feeling like there's some bad thing going to happen. They'll be telling you, "Help me." They become more restless and don't know what they are doing. When you hear profuse sweating and also diaphoresis, this is a sign that this person is having an acute episode, especially in pulmonary edema, and you need to act as quick as possible before you lose your patient. Long-term complications, the extremities will be cold, and also the person will be cyanotic. So, what are some of the things that you can also do? Immediate management of the acute episode. Now, the first thing is oxygenation. I did talk about with the heart failure. So, again, when they are having an acute episode, put them in a high Fowler position, give them oxygen. Prepare to give furosemide. So, you start an IV, and also prepare to administer diuretic, morphine sulfate. These are things that you should know, especially because nitroglycerin is not going to do the job over here. Then you are going to be inserting a Foley catheter to know how much the patient is peeing or how much is coming, to see if the furosemide is working or not, or the diuretic is working. So please, 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 please be careful. If everything fails, you prepare the person for intubation or ventilator support if there's a need. So the whole thing will now turn into a cardiac problem. What do you call it? Respiratory problem. Now let's look at the infection of the heart. The first thing I'm going to talk about is inflammatory disease of the heart. So what are the inflammatory disease of the heart? Anytime you have an infection, think about the word cyst. So there are three layers of the heart. The first one is called uh, the peri. So the peri, we have endo, we have myo. So we have peri means the outer layer of the heart is called the pericardium. And so the inner layer of the heart is called, the innermost layer of the heart is called endocardium. And then the middle layer is called myocardium. So when there's an infection, depending on the location, will determine the name. So let's start with the innermost layer of the heart, which is called endocardiasis. With endocardiasis, the first thing you need to know is that the innermost layer of the heart is being, there's an infection in the innermost layer of the heart. This usually occurs primarily in clients who are IV drug users. And please, when you talk of IV drug users, they also come out with hepatitis C. Most of the time, it's meant common among them. So, IV drug users, they have the chance of getting infection, especially the innermost layer of the heart. So when the innermost layer of the heart is also infected, that's where our major problem is going to be the forming of a vegetation around the valve. So when that happens, that which is like a clot, it can dislodge itself and then find itself in the brain. or any part of the body. It can go to the lungs and cause pulmonary embolism. It can go to the brain and cause stroke. It can also go to all the way to the renal system and cause renal problem. So port of entry of these organisms or the infection include the oral cavity. And so that's why when you go in for your surgeon, you need to make sure that you let the doctor know. And then usually after the procedure, what they do, they put you on antibiotics after any dental procedure, especially when it comes to extractions. Surgery is also another one. So that's why after surgery, they put the person on antibiotics to help prevent all this from happening. If you have an IV line or central line and you're not properly taking care of that, again, what happens is that you can introduce bacteria into the heart and cause endocarditis. So this time around, we have infection. So because we have infection, white blood cells will go up, and then the person will also have fevers. This time around, temperature will go up as well. So with endocarditis, you should be expecting fevers, fatigue, cardiac murmurs. You can have a heart failure because of the infection. And again, the person will be having weight loss if they have endocarditis. Remember, there's an infection, and therefore the heart will not be able to be pumping blood the way it's supposed to be. Our main complication is that when we have this vegetation or embolic complication and of the vegetation, that is when it got dislodged, it can go into the circulatory system and cause a lot of problems. One of them, like I said, it goes into the brain and cause stroke. So please take note of that. Then we also have petechiae and then also the crabbing of the fingers. These are all long-term complications that you can see. Um, but then when the clot forms and then it gets dislodged, like I said, it can cause go to the spleen and cause splenic emboli. And how do you know? This time around, the person will be having a sudden pain that is radiating to the left side, or we have rebound abdominal tenderness on palpation. Then we have the renal. That is when the clot goes in there. This time around, when we have a renal problem, think about flank pain. And this will be radiating to the groin. And then also monitor when it comes to renal, you're monitoring difficulty peeing, that's pyuria. And then also that's painful when you're peeing. And then also hematuria when they are peeing blood. You'll be monitoring for confusion, aphasia, dysphagia, which may indicate central nervous system emboli. And when it goes into the pulmonary system, it's going to cause PE. So please take note of that. And with this one, you'll be having pleuritic chest pain. Remember, if it is myocardial, if it is a cardiac and the patient is complaining of a chest pain, when you inspire or expire, it doesn't change the intensity of the pain. But if the chest pain is increased because you have pleuritic chest pain, then it's more related to respiratory. So please take note of that. The patient will be having dyspnea and then they'll be having cough as well. So evaluate blood cultures. Because it's an infection, we'll go to getting blood cultures. And blood cultures will help us identify the what is causing the infection, and then the doctor can put them on the appropriate antibiotics. But always remember, when the culture is ordered and antibiotics is also ordered, you take the culture first before you start the antibiotics. The next infection that NCLEX love to ask is pericarditis. So with pericarditis, what is happening is that the patient is having infection in the outer layer of the heart, and that's what we call pericarditis. With acute pericarditis, you can have acute pericarditis and chronic inflammation of the heart, which we have the chronic inflammation of the pericardium. So it could be either acute or chronic. But what you need to know is that it is the outer layer of the heart that is involved. So the pericardial pain usually, again, they are going to have a chest pain, and this chest pain will radiate again to the left side of the heart and also to the back, to the shoulder, because this is cardiac related. So pain usually is aggravated by breathing. So because this time run, the patient, this one has to do with the heart, and also this patient will be building up. The patient is no more, the heart is no more pumping the way it's supposed to be pumping. Sometimes there will be a fluid buildup in the lungs. So when this person breathes, it affects the intensity of the pain. So when the intensity of the pain is affected by breathing, usually particularly with inspiration, think about pericardial or pericarditis. This pain can also be increased with coughing or swallowing. Pain is worse when the patient is in a supine position and may be relieved when they are leaning forward. This is more of orthopnea. That is difficulty breathing when you are lying in a supine position, but their breathing get better when they are in a sitting position or they put pillows on their back. This one, I want you to take note of this one, pericardial friction rub. Pericardial friction rub, when you auscultate, you hear that. This is a scratchy, high-pitched sound that you are going to hear when you auscultate them. So please remember, pericardial friction rub, and also the intensity of the pain get worse when the person is breathing in or breathing out. So please take note of that. Um, The other thing, because it's an infection, this patient will be having fevers and chills, and then fatigue and malaise is also one of the things that you should be thinking about. So again, white blood cells will go up, remember, because it's an infection, and then we have electrocardiographic changes, which will cause pericarditis, and also the person can get atrial fibrillation, which is more common, and the right-sided heart failure can also uh, a sign of right-sided heart failure in the clients with chronic pericarditis. So, what are some of the interventions that we can put in place for this patient? One, you assess the nature of the pain. We already know how this pain is going to be. This pain is going to be worse when the patient is breathing in. And again, the patient will say that the pain is radiating to the back or to the left jaw. These are all things. Now, one of the things that you can do for this patient is to sit them up or put them in a high fallow position, let them be sitting upright and leaning forward. You want to give them oxygen as well. So you can see that the same thing that we did for the previous patients, we are doing the same thing over here. Because it's an inflammation, you want to give them, because they are in pain, you want to give them NSAID as well. You also want to give them, you auscultate for any pericardial friction rub. So this is where the patient pain get well, yeah, you auscultate for the percussion friction rub. You check the results of blood cultures to see which organism is causing the infection, and then also prepare to give the antibiotics, which is the same thing as the endocarditis, how we treat them. But the problem is that you are going to be monitoring what we call cardiac tamponade or cardiac tamponade. So this is where when you have fluid buildup in the pericardial side, it causes or it prevents the heart from contracting, or it affects the contraction of the heart. And when that happens, this person will be getting cardiac tamponade. So when that happens, the doctor will have to find a way to get this fluid out. So this is a medical emergency when it comes to cardiac tamponade. I'll talk more about that, which is my next slide. Any sign of cardiac tamponade is a medical emergency. You need to report that to the doctor right away, because this you might lose your patient. So what is cardiac tamponade? So cardiac tamponade is when you have accumulation of fluid in the pericardial cavity. So when the pericardial cavity is filled with fluid, remember there's an infection in the pericardial sac, which is the outermost layer of the heart, and therefore fluid will be able to be built in there. So when that happens, this restricts ventricles from filling up and also affect the cardiac output. Now with the acute cardiac tamponade, This can occur when the fluid, I mean the fluid volumes get to 20 to 50 ml when accumulated in the pericardium. So this will put pressure on the ventricles and they can no more um, pump the way they are supposed to be pumping. In this case, what are the assessments that you're going to be seeing since it's a sign of a heart failure? One of the things is that the blood pressure is going to drop. Then you are going to be thinking about venous jugular vein distension again. Remember, so heart is no more pumping the way it's supposed to pump, so the jugular vein will come out. And again, you'll be hearing since there's a fluid buildup. So when you listen to the patient's heart sounds, you'll be hearing a distant heart tone. So always remember that. And then there's going to be a narrowing of the pulse pressure. So when we talk of a pulse pressure, for example, when I have a blood pressure of 120 over 80, my pulse pressure is going to be the systolic, which is 120, minus the diastolic, which is going to be 80, and then I'll get 40. So this value, 40, the difference between the systolic and the diastolic is what we call the pulse pressure. So when it gets narrowed and narrowed, then definitely we say that it's a sign that the patient is having cardiac tamponade and this person has to be prioritized. So what are some of the interventions? The interventions are you have to administer fluid um, intravenously as prescribed to manage the decreased cardiac output. Remember, the fluid volume is going to drop, the blood pressure is going to drop, so you should be prepared to give fluids to increase the fluid in the system. You want to prepare the client for X-ray, so the doctor will order an X-ray and see the structure of the heart. Again, with X-ray, you know what to do. Patients should not be pregnant, and also echocardiogram. The doctor will, because it's a fluid, the doctor will listen to the sound and then we'll be able to come out with some diagnosis. So echo, when the patient is going for the echo, you know that this is not an invasive procedure. You don't have to put the person on MPO. And again, unless it is the transesophageal, uh, which is going to be more of an invasive, but other than that, please, you don't need an informed consent for this. Then the main thing I want you to know is that this patient is at risk of, because the fluid is building up in the pericardium, you have to put, you have to, the doctor will have to go in there and bring the fluid out. And that's what we call the pericardiocentesis, to bring the fluid out. I know it's a lot, but the last one I'm going to talk about for this section is going to be more of the last one, which is going to be the cardiogenic shock. So let's talk about cardiogenic shock. So cardiogenic shock is when there is a failure of the heart to pump adequately, thereby reducing a cardiac output and compromising tissue perfusion. That is a shock here. So the heart is no more pumping. So it just stops pumping. That's cardiogenic shock. So when that happens, there is going to be a cell damage. So the necrosis, which we talked about, is cell damage because not every part of the body is no more is now getting the blood. So necrosis is more than 50% of the left ventricles. So when the left ventricles, you keep getting the myocardial infarction, and 40% or more of the left ventricles are cells are dead, then what is going to happen is that um, you can get cardiogenic shock. There'll be a time the heart will stop pumping. Now, the goal or the treatment of this is to provide the oxygen. So remember, the main problem with the heart is the main thing function of the heart is to what? To pump oxygenated blood to all parts of the body. So when that happens, what is going to happen is that our main intervention is going to be oxygenation and perfusion, and this will help improve the when that happens, the heart muscles will help the heart will begin to improve and then start pumping back again. So what are some of the assessments that we need to know as far as cardiogenic shock is concerned? Now, because it's a shock, remember the heart is no more pumping, so blood pressure is going to drop. So again, blood pressure drop more than 90 millimeters mercury of the systolic, and sometimes the 30 millimeters mercury uh, or 30 millimeter mercury based on the baseline that the patient is having. So one of the things about shock is that the blood pressure is going to drop, and again there will be tachycardia. So when your blood pressure is dropping and then the heart rate is going up, it's a sign that the person is going to shock. And then we have tachypnea. Tachypnea is increase in the respiratory rate. Then because the patient blood pressure is dropping, the urine output is also going to be something you should be monitoring. The normal urine output is between 30 to 50 ml per hour. So you have to be monitoring the patient's urine output. Since there's a problem with oxygen moving to all parts of the body, you'll be assessing the extremities for cold and clammy, and also poor peripheral pulses is something that you should be assessing as well. And then there will be a delay in capillary refill, pulmonary congestions, and pulmonary congestion, and impaired peripheral perfusion, which you need to know. So since the heart is no more pumping, blood will not be getting into the extremities like the fingers, the toes. Those are the things that you should be looking at. Um, Disorientation is also another thing that you should know. And then restlessness and confusion. These are all things that shows that we have less oxygen going to the brain. And then also we have agitation and anxiety. Okay. So what are the diagnosis steps? So the one thing with cardiogenic shock is that the doctor will order an EKG, an X-ray, echo, or BNP, this and troponin, because all of them will result or can result in the cardiogenic shock. So interventions are you give oxygen as prescribed, administer morphine sulfate to control the pain, and also prepare for intubation and mechanical ventilators, which we already talked about most of the time. If it is fluid of and the person is getting is retaining fluid, you want to give them diuretics if necessary. But most of these interventions we've already talked about them. We're going to end here with a part one, and then next time I'm going to talk about is going to be the vascular problems of the heart. So I'll be talking more about the arterial disorders. For now, I think you should be good for now, and be looking for part two um, of these slides.